We're at the IAS meeting in Amsterdam. We're here with Ambassador Goosby, who has been awarded a number of prizes for the outstanding work you've done and your commitment. I guess obviously you don't get awarded anything without a commitment to what you're doing. And I think that's what can be said most about you. But so tell us a little bit about your background. I know we've interviewed you over the years, but some of your previous work and where you are now.
Sure. Thank you. It's always a pleasure. I started as a medical student, medical resident at San Francisco General, University of California, San Francisco School of Medicine. Went there in the late 70s, did my internship, residency, fellowship, chief's year there, and the HIV events in San Francisco bubbled up underneath us. My work then focused on working with my colleagues at UCSF to set up the first AIDS clinic at San Francisco General. I was the medical director of that, with Paul Voberdine, Connie Woofsy, Don Abrams, and the inpatient unit, first outpatient and inpatient unit dedicated to HIV in our country, and did that until 1991, when and that was full of research and a lot of implementation research, but mostly antiretroviral research. Then in 1991, I was asked to set up the Ryan White Care Act, which was a program that was federally funded after Senator Kennedy and Hatch lobbied for years to get it passed, that focused on indigent AIDS patients in 52 epicenter cities in the United States. And I set up a continuum of care and services in each of them, and also set up enabling services around those basic service clinics to identify, enter, and retain people in care over time. In the 90s, President Clinton, in addition to Ryan White, I stopped doing that and became the HIV/AIDS policy director for Donna Shalala. And in that capacity, founded, conceived of the guidelines for antiretrovirals, was the chair of that committee for 14 years. Still runs to this day, and is still the main reference for people to see which drugs they should use, how they should switch them. When President Obama took office, I, with Secretary Clinton, became the director of the President's Emergency Plan for AIDS Relief.
You were the second.
I was the second. Yeah. Mark Dybul was the first.
Right.
Mark Dybul was the first medical director. He started the program in 2003. I picked it up in 2008, and then did that until 2013, first couple of months, 2014. And in our time with President Obama and Secretary Clinton, took the program from about 1.7 million up to about 7 million people on antiretrovirals. Right. Started the prevention of mother-to-child transmission program much more intensely, basically everywhere. And really wanted to attack pediatric HIV with that, and dropped it more than 50% with that effort. By the end of the time, my time, we had gotten up to 11 million people on antiretrovirals. Dr. Ambassador Birx has taken that further and has pushed that up into the 15, 16, 17 range. And with the combined effort of the Global Fund, we're now at over 20 million people on antiretroviral care, stably on it, not just started. Right. So I think it is a remarkable journey.
Yeah, and now your new job.
So now, Ban Ki-moon, Secretary General, as he was stepping out of his tenure, and as I was stepping out of the PEPFAR role, asked me to consider taking on the Special Assistant Envoy for TB position to intensify the response to tuberculosis. Ban Ki-moon saw that I had just been in the 22 heaviest hit countries for HIV are also the same for TB.
About it, right, yeah.
So, but the same, the thinking was, I think, that I already knew the leadership, had interacted with them for years in the PEPFAR capacity, and wouldn't it facilitate things with that relationship already secured to bring in tuberculosis? So for the last 3 years, I have focused on the huge overlap that HIV and TB present. They are bedfellows and comrades in mischief. TB has found the HIV community and has stayed in it and remains the leading killer globally of people who are infected with HIV. There are probably 550,000 people who have their death attributed to TB who have HIV, so a strange statistic. But that connection really puts these two diseases bound at the hip, and medical delivery systems need to understand that and accommodate the identification, entry, and retention of people with TB just as aggressively as they do for HIV. HIV platforms need to look for TB, diagnose and treat it. TB platforms need to look for HIV, diagnose and treat it.
And now there's multiple forms of TB. There's the TB, MDR TB, and XDR TB. How does that play out in the international world?
It's probably our largest concern. If you look at all antimicrobial resistance, the development of antimicrobial resistance for antibiotics as well as antimycobacterial
That's
drugs.
scary. Yeah.
Tuberculosis is the leading antimicrobial that has developed the most resistance. So out of the 500,000 people who die from antibiotic resistant deaths related to antibiotic resistance, tuberculosis makes up a quarter of those people. It's the largest group. So TB and antimicrobial resistance concerns rises to the top. Our awareness of multi-drug and extremely resistant TB, XDR, MDR, has increased. Our surveillance systems have matured, and we're now understanding where it is more specifically and how it has or hasn't moved through populations. The Eastern European countries are the backdoor entry that has been knocking for about a decade, largely unresponded to because of the political chaos in many of the countries and lack of prioritizing health and TB specifically as a target. It is right on the back door of Europe, and that is a true threat. But MDR TB is in every country. It's been in every country for over a decade, but at low levels. HIV hit the street and the levels started to go up, but we have seen that and responded to it. It still needs intensification because to treat regular tuberculosis, drug-sensitive TB, is under $50 for the whole 6-month course. To treat multi-drug resistant, it goes up to, on a global number, about 100 times that cost.
Wow.
And XDR about 2,000 times that
Oh
cost.
my God.
XDR will bankrupt developed country budgets. And in the United States, for example, it can cost 10 to 27,000 is the range to treat successfully MDR, XDR. Drug sensitive is a 6-month treatment, pills, no shots. MDR and XDR require pills and shots, 5, 6, 7 drugs, very toxic drugs, one of which, an injectable streptomycin, causes deafness in 12, 15% of the people who get it. And it's not a drug that you can stop. The regimen will not be successful without it. So you've got to just stay on it even though your hearing is waning.
It's like amphotericin.
It's the same class of drug as amphotericin. It's an aminoglycoside. They're cousins. And the drug is a bad actor for antibiotic use as well. We've gotten so good at giving it intravenously that we titrate the level so it stays below the level of toxicity.
Right.
But it requires monitoring every day, sometimes twice a day, to do that in an inpatient setting. In an outpatient treatment for TB, you don't even monitor drug levels. It's a standard shot. New drugs are on the horizon for TB, and that's the good news. That
was what I was going to ask you.
Yeah.
It's really the key.
It's the key. I mean, we saw that in HIV. I know you've reported on that evolution with HIV. Our ability to keep new drugs in the pipeline allows us to keep resistance abated because the person starts to fail with their current drugs and we've got alternatives. With TB, that is not the case. The 4 drugs that are used for drug-sensitive TB were discovered in the first one, the injectable, was in the late 40s, just after World War II.
Yeah.
And then the 50s and 60s was the big increase in INH and rifampin. And that changed the effectiveness of TB treatment. It brought the cure rate up to 84%. Any people on those drugs, 84% of them are cured. But no new drugs were developed until the last 4 or 5 years. 5 years ago, R&D started on new drugs and new diagnostics. The new drugs, there are 2 new drugs that are very promising, one of which is available on a kind of compassionate use basis. It's also available to the 22 high-burden countries globally through USAID's program. They can donate the drug to the country. But it requires a sophisticated system to take that drug and use it in the appropriate way. The drug's called bedaquiline, and we're very excited that it has changed the need for the injectable. It replaces the injectable with an oral drug, and will revolutionize our ability to treat MDR. Interestingly, it's sensitive. It's also effective in drug-sensitive Mycobacterium TB, and it raises the question: should we change the initial regimen for drug-sensitive to include that? Probably we should. South Africa, in this conference, announced, I guess 2 days ago, that they are going to use the bedaquiline instead of the injectable for MDR, XDR right now. So they're the first country to jump in and take it. The kind of phase 3 studies and efficacy studies have been completed on the drug, but they haven't been published, and it's not generally on formularies like that. So South Africa is really leaning forward to minimize the risk to the patient population currently in care. So it's a real heroic act.
Well, I appreciate you taking the time with us, and I know that Ban Ki-moon made a good decision in selecting you for this position because you're so engaging, you're so real, and I think that's the thing that comes across really strong. You're no BS. It's all out there. You're telling the people like it is, and it's going to be critical to get those policy changes and governments that pay attention to the real word that needs to be heard.
It is.
And
You're very kind to say that. Thanks.
Well, I'm sure I'm not the only one saying that, because it was an obvious choice.
Well, thank you
so much for your help, and
Pleasure.
good luck. Good luck.
Thank you.